بكم جديد وصباح الخير اللي في السعودية ومساء الخير للي هنا عندنا في كندا وأمريكا. أشكر كل اللي شاركوا معاي أمس في الحالة الأولى. واضح إنه اليوم راح يكون الكلام بشكل علمي، أغلبه حيكون إنجليزي ومصطلحات علمية. إذا حابين تعملوا سكيب، وبكرة إن شاء الله أتكلم عنها للتثقيف العام بالعربي. أغلب التوقعات كانت systemic lupus erythematosus SLE بحكم الراش في الوجه. هذا من ضمن ال differential diagnosis. طبعا صعب من غير history انك تعتمد على تشخيص واحد. بعضهم قال dermatomyositis و sunburn. بالنسبة لل systemic lupus erythematosus القصد فيها ال acute cutaneous lupus erythematosus و specifically الميلر rash. لو ركزتوا في الصورة بتشوفوا ال sparing للنيزل bridge، ف by definition it's not the butterfly rash. For the malar rash, sparing of the nasolabial fold. بالنسبة للصورة كان عندها involvement under the nostrils. Diagnosis is rosacea، هتكلم فيها إن شاء الله، ومن ضمن الكلام I will talk also about the differential diagnosis. Rosacea is in the spectrum of adenyxal diseases, which involves the hair follicular unit. In Caucasians, specifically skin types 1 and 2, the worldwide prevalence is 2 to 3%, but in countries like Sweden it's 10%. It's more common in middle-aged women, and there is a 10 to 20% report of family history. Recently there have been studies about sharing of the genetic loci for rosacea and autoimmune disease. Specifically type 1 diabetes, celiac disease, multiple sclerosis, and rheumatoid arthritis. Genesis is unknown. There are a couple of theories, such as upregulation of cathepsidins that induce angiogenesis and are pro-inflammatory. Exposure to ultraviolet radiation may induce angiogenesis, causing upregulation of reactive oxygen species that cause dermal damage. Theories are the vascular changes, neurogenic inflammation, which make the threshold of vasodilation low. Increased infestation of Demodex mites in rosacea patients have shown to increase perifollicular infiltration with CD4 T helper cells. Classification of rosacea is erythematotelangiectatic, papulopustular, phimosis, and ocular rosacea. Erythematotelangiectatic, you get easy flushing, persistent centrofacial erythema, and telangiectasia. Papulopustular variant, you get either papules, pustules, or papulopustules with persistent centrofacial erythema. This rosacea has a male predominance. It's usually thickened nodular skin due to hypertrophy of the sebaceous glands underneath. The sign is prominent pores, and it usually happens in the nose, chin, forehead, eyelids, and ears. Ocular rosacea, patients complain of dry, itchy, gritty sensation, burning pain, photosensitivity, blepharitis, keratitis, and iritis. Common triggers that causes the flushing and erythema, such as hot and cold temperature, wind, hot drinks, spicy food. Exercise, topical irritants, some medications, and alcohol. Diagnosis is based on the subtype that the patient presents with. In the erythematotelangiectatic, you can think of the following. Carcinoid is another possibility, and you have to think about medications that cause flushing, like calcium channel blockers, morphine, prednisone, amiodarone. Pustular variant, think about acne vulgaris, perifacial dermatitis, Demodex folliculitis. In terms of treatment, the most important thing is patient education. He has to know it's a chronic relapsing disorder. That means maintenance therapy. It's important to educate the patient about avoiding the triggers for erythema and flushing, and sun protection with appropriate sunscreen. The treatment appropriate for the subtype is very important, so classifying the type of rosacea is the first start for managing the patient. Erythematotelangiectatic rosacea, azelaic acid 15%, also metronidazole gel or cream is appropriate. Treat the inflammatory portion of the disorder, but once the telangiectasia develops, laser therapy is the treatment of choice, usually IPL. For the papulopustular rosacea would be Metrogel, Metro Cream, azelaic acid, clindamycin topically, tretinoin, benzyl peroxide with clindamycin. These are all for the mild to moderate cases. As for the moderate to severe, you would use tetracyclines such as minocycline or doxycycline, and also isotretinoin is a good option. Just rosacea, if it's early in the course, isotretinoin is a good option. For advanced cases, surgical debulking and CO2 laser. Rosacea, good eyelid hygiene, artificial tears, metronidazole gel can all be applied. Also doxycycline or minocycline. Another option is cyclosporin, 0.5% ophthalmic emulsion. But also it is very important to refer these patients to an ophthalmologist. This was helpful. I hope the first case wasn't too challenging. And if you have any questions about the case we discussed today, feel free to ask me.